Today we're going to be looking at the role of gastroesophageal reflux in the pediatric airway disorders. These are my disclosures. So gastroesophageal reflux, the definition is regurgitation of gastric contents into the esophagus. Although there is some degree of reflux, which is normal in infants, and very often small amounts of regurgitant occurs with small amounts of food without any adverse effects. Problematic reflux results in esophagitis, profuse vomiting, feeding difficulties, poor weight gain, and failure to thrive. And these children then develop gastroesophageal reflux disease. Apologies, I'm just getting to my slides. So the anti-reflux mechanism has at least two sphincter-like mechanisms. The first being the intrinsic muscle sphincter known as the lower esophageal sphincter, and the diaphragm that functions as an external sphincter-like mechanism. The lower esophageal sphincter is the major component of the anti-reflux barrier. With regards to the diaphragm, the lower esophageal sphincter lies within the hiatus that is created by the right crew of the diaphragm and is anchored by the phrenoesophageal ligaments. Now, this anatomical arrangement is the intrinsic support of the lower esophageal sphincter, and loss of this support through development of a hiatus hernia significantly compromises this function of the sphincter. The majority of reflux episodes occurs because of two mechanisms. One, where there's intermittent, brief, complete lower esophageal sphincter relaxation, or there's transient lower esophageal relaxations. And this is thought to be the major component of reflux episodes, rather than just chronic absence of lower esophageal sphincter pressure. So the etiology for gastroesophageal reflux is still unknown, but there are, with regards to laryngopharyngeal reflux, the pathophysiology is fourfold. One, inappropriate lower esophageal relaxation, delayed gastric emptying. Often these patients have reflux in recumbent positions, mainly upright and daytime reflux. And there's also associated upper esophageal dysfunction as well. So the flow of gastric contents in reflux can go all the way up to the pharynx, and this is where the problem lies with Laryngopharyngoreflux, or LPR, as I'll call it from now on. And it's a cause for many ear, nose, and throat diseases. The classical symptoms of gastroesophageal reflux disease are often minimal or absent in these patients, and most patients can have symptoms of vomiting and esophagitis, but most patients have minimal or absent symptoms. Now, LPR has a different diagnostic criteria, although the treatment options are still similar to that of gastroesophageal reflux disease. Now, there are four barriers to preventing reflux onto the larynx. There's the lower esophageal sphincter, there's the upper esophageal sphincter, there is esophageal peristalsis, and then there's epithelial resistant factors. And dysfunction in any of the above that I've mentioned will lead to symptoms of LPR. It is a common pediatric disorder. The incidence is about 10 to 18% in the general pediatric population. And patients and children with esophageal malformations or neurological disorders, up to 70% of them have associated LPR. And this number has also increased in the past decades. Symptoms, as I said, are variable and are different to gastroesophageal reflux disease. And often result in underlying damage to the mucosa and the adjacent structures around the larynx. Patients in the general population often have spontaneous resolution after 1 to 2 years following the onset of LPR. So, like I said, LPR is distinct from gastroesophageal reflux disease, as there's direct mucosal damage from acidic exposure, which is typically found in the upper esophagus that damages the laryngeal epithelium. And this results in ciliary flow dysfunction. As we know, ciliary flow is impeded at a pH of 5 and completely halted at a pH of 2. So with decreased ciliary flow, there's decrease in resistance to infection as well. The retrograde flow of the gastric acid and pepsin induces laryngeal mucosal damage and impairs this mucociliary resistance to infection and ciliary clearance. And there are three different theories that could potentially explain the damage to the laryngeal epithelium. There's direct contact of the acid and pepsin with the epithelium that induces damage. There's gastric refluxant with additional voice abuse that causes symptoms and chronic coughing. And then there's mucosal lesions, and the esophageal bronchial reflex theory suggests that acid in the distal esophagus vaguely stimulates a chronic cough, which can induce laryngeal symptoms as well. And specifically histologically, when we look at LPR, the inactivated pepsin, which is at a pH of 7, is taken into the laryngeal cells. And this was a study done looking at post-cricoid cells. And they found that once the inactivated pepsin is taken into the cells, there's subsequent reactivation within the cells, which causes mitochondrial damage and then overall cell damage. So it's a very different entity to that of gastroesophageal reflux. So there are age-related symptoms when looking at LPR. So in infants, we often see it manifest as regurgitation, vomiting, dysphagia, failure to thrive, apneic episodes, patients with recurrent croup, persistent cough and aspiration. In childhood, it becomes a little more different. There's a chronic cough, there can be dyspnea, dysphagia, chronic sore throat, hoarseness, halitosis, and a globus sensation. And then as they reach teenage years, it becomes very similar to that of adults with regurgitation, heartburn, vomiting, nausea, and chronic respiratory issues if it's ongoing. So the dilemma here is that there is disorders of ears, nose, and throat, which are common in children. And physiological reflux is common in children. These two may coexist without there being a causal relationship. And the challenge here is when to commence patients on treatment without classical features of gastroesophageal reflux disease. So that's the real question for ENTs. So looking at how it impacts on ENT disorders, within the airway, LPR can affect patients who have Laryngomalacia, subglottic stenosis, recurrent Papillomatosis, and chronic cough. They can have dysphonia, associated sleep disorders, and adenoid hypertrophy. And LPR has also been associated with chronic otitis media with effusion and tonsillitis. And then with the lower airway patients who have associated LPR or have associated LPR, these are the patients we are going to look at today: asthmatics, recurrent bronchitis, pneumonia, and acute life-threatening events. So looking at Laryngomalacia, excuse me, it's one of the most common causes of airway distress, and up to 65% of patients with severe Laryngomalacia have LPR. And we see that there is a direct contributory factor of LPR to the worsening of Laryngomalacia through mucosal edema. The exact mechanism is not quite known, but the proposed mechanism is mucosal edema. And as I've said before, pepsin has been found in laryngeal mucosa in many studies done recently. There's another study that looked at patients with abnormal sensory motor function within the larynx with congenital laryngomalacia, and it was done in 2007. And they found that patients with moderate laryngomalacia were more likely to suffer from LPR than those with mild laryngomalacia. And multiple studies have reported improvement of laryngomalacial symptoms after commencement of LPR, although these studies are few, they're small, and they're not controlled. In the study that I've quoted in 2007, they also showed that patients who had supraglottoplasty had improved pH monitoring post-surgery. This study over here is a retrospective cohort study which compared the risk and time with supraglottoplasty and the frequency and duration of hospitalization of infants. And this was done in 2017 at Boston University. And in this study, the primary outcomes were supraglottoplasty requirements, the time to supraglottoplasty, and hospitalization risk. 36 subjects were in the study. This is one of the biggest studies that I could find in the literature, with a mean age of 62 days. 55% of these patients were put on acid suppression. And in this study, it shows that acid suppression does not always reduce the frequency of supraglottoplasty related hospitalizations as compared to those that were not treated. Although what it did find was that thickening of the feeds had a positive effect on these patients with decreased hospitalization, and also showed longer waiting times before supraglottoplasty required. So that was the study's recommendation, that maybe thickened feeds rather than acid suppression has a beneficial effect. Looking at subglottic stenosis, this is actually the most extensively studied airway condition that's related to LPR. Most of the studies have been done on animal studies. We're looking at gastric acid and pepsin. The mechanism thought is that for the development of subglottic stenosis is pepsin-induced inflammation, fibrosis, thickening, and then luminal stenosis. There have been a few uncontrolled human studies which show that 2/3 of patients with subglottic stenosis have LPR, and of these children, 1/3 of them were put on, and of these children that were put on acid suppression, 1/3 of them avoided any surgery. But this is often patients with grade 1 subglottic stenosis. Other factors that confounded these studies included trauma and infection. So looking at a recurrent croup, not much studies have been done looking at the causatal effect of LPR on recurrent croup. One of the studies I had a look at was a retrospective case note that looked at patients, children with recurrent croup, that were referred to a ENT service in China, and they looked at patients from 2002 to 2011, and they found about 90 children with recurrent croup, and they found that 25 of these patients, or 28% of these patients, had anatomical airway abnormality, of which 16 of them demonstrated degrees of subglottic stenosis. So there was a confounding factor to, even though these patients had recurrent croup and LPR, there were other potential factors that could explain the recurrent croup. And only 26% of these patients had positive microlaryngoscopy findings suggestive of reflux. So whether there is a cause or an effect is difficult to say, but in the one of the studies quoted at the bottom of the slide, they found that 87% of children improved on anti-reflux medication. So the question in this study was, yes, it does help, but with these confounding factors, treatment of those factors alone without anti-reflux medication could have also resulted in improvement. So looking at recurrent respiratory papillomatosis, here the thought is that there's direct damage of the respiratory epithelium. And it has two effects. One, it could facilitate the onset of patients with HPV infection and the onset of papillomatosis. And patients with established respiratory papillomatosis, their symptoms can worsen with uncontrolled LPR. The other concern is that the surgeries and frequent scopes and debulking of these papillomas can result in scarring and fibrosis, as we know. But patients with LPR, there is an association that these patients, sorry, I don't know why my slides jumped, apologize about that. Why these patients have more frequent development of scarring and fibrosis. And the treatment of LPR is thought to reduce the complications and the progression of respiratory papillomatosis. Hoarseness, this is quite a common thing we see in the adult population, and there are multiple studies to show that there's a strong association of hoarseness and LPR in adults, although the role in children is not very well established. Often these children that do have hoarseness with LPR have vocal cord nodules, and the hoarseness seems to worsen the interarytenoid edema and chronic inflammation, which worsens the dysphonia. Treatment really of these vocal cord nodules is really pharmacotherapy and speech therapy. So for patients that present with hoarseness, that have associated vocal cord nodules, these patients require speech therapy as well as acid suppression. Looking at patients with asthma, in the literature, it was found that 40 to 80% of children with asthma have gastroesophageal reflux disease. And 70% of these patients with gastroesophageal reflux disease have shown laparoscopic changes of LPR. The theory here is that patients who have used chronic MDIs, such as beta agonists, have shown that they have a lower tone of their lower esophageal sphincter, and this obviously, as we know, can trigger reflux. Also, patients who have uncontrolled asthma have a higher risk of developing LPR. And once again, the thought here is that there's an increased use of their beta agonists. Looking at chronic cough, Chronic cough is defined as cough that lasts for more than 4 weeks. And often these children, there's a multifactorial reason why they have chronic coughs. And most patients who have chronic cough have either all of these LPR, allergy, and asthma, or have a combination of the above. And it's thought to be, as I said before, there's a triggering of the diaphragm, a vagal response, triggering of the diaphragm that results in chronic irritation, that results in chronic cough, that can lead to triggering LPR. So looking at sleep disordered breathing, very little has been written in the literature on children regarding sleep disordered breathing and gastroesophageal reflux disease. However, in a few small studies, they found that patients who do have sleep apnea are 5 times more likely to reflux. But whether this is a cause or a consequence of the sleep apnea, there's not enough studies at the moment in literature to establish that correlation. Reflux and the nose, and specifically in children, often these kids have adenoidal hypertrophy. They can present with neonatal rhinitis. Patients specifically with choanal atresia, there are some small studies to show that patients with LPR have an increased incidence of restenosis after surgery. And there is an association between children with chronic rhinosinusitis and reflux. So looking at sinusitis, the relationship here is that the reflux induces chronic inflammation of the nasal cavity, which, as I said before, results in ciliary clearance inhibition, which results in changes in the mucosal bacterial adherence of the epithelial lining, and also prevents lymphatic drainage. And this can result in stasis within the sinuses, resulting in sinusitis. There was a large study done that showed that 75% of children with chronic sinusitis had abnormal pH testing within the nasopharynx, and that allergies may be present, and that allergies sometimes are present with patients who have LPR, and sometimes it's difficult to distinguish patients who have allergic rhinitis versus with adenoidal hypertrophy and patients who have LPR with adenoidal hypertrophy. Although in this study specifically, they showed that patients that were treated with acid suppression did have a decrease in sinus symptoms and a decrease in need for surgery in children, specifically looking at adenoidectomies. Reflux and the ear. There are a few studies out there, and specifically the one I've quoted, number 2, this article was done in 2021, looking at the association of gastroesophageal reflux disease with increased risk of chronic otitis media, and specifically otitis media with effusion. In this study, they specifically looked for pepsin in middle ear fluid and found that in these patients, there was up to 1,000 times more concentration of pepsin in the middle ear fluid than in blood plasma. This study also showed a correlation between patients with H. pylori infection and middle ear effusions as well. And then patients who have increased episodes of reflux, looking at impedance studies. In this study done in with Tosca et al. Showed that patients with LPR present, so 19 out of the 28 children looked, looked at with impedance testing, 19 out of 28 of them had LPR. Also determined that children with reflux in infancy were more likely to develop hearing issues later on in childhood. And then the question that the study had was whether LPR, we know that LPR is associated with OME, but whether LPR causes otitis media with effusion is still a question that needs to be answered. And does treatment with LPR improve otitis media with effusion? How do we treat these patients, and who should we treat? There's not enough studies out there to with specific guidelines regarding these questions. So looking at how to assess for LPR, there are a lot of questionnaires out there for adults, but there's very minimal studies out there or questionnaires out there specifically related to children. And the one study did look at infant gastroesophageal reflux questionnaire, which was revised, and this was validated and tested and found to work well for infants under 18 months, but not for children over 18 months. There is, however, a group in the Netherlands that looked at the reflux symptom index that we use commonly for adults, and they primarily use this for patients under the age of 2, and it showed a sensitivity of only 13%, but a specificity of 83%. So this is still an ongoing process with regards to having a proper questionnaire for children specifically. So looking at the assessment of LPR, specifically endoscopy of the airway, adults have different symptoms, have different signs, and they are not the same as children. And in children, often they can have in adults, they can have granulomas, they can have some subglottic edema, and they can have some ventricle obliteration. Whereas children, they get this pachyderma, they can get this lymphoplasia, blunting of the carina, and often these children can have lingual tonsillar hypertrophy. And the adult reflux finding score is not ideal for the pediatric population, and there's currently no reliable score that's equivalent to this adult reflux findings, the reflux finding score for children at the moment. So assessment of LPR, you can also do oesophagoscopy. You can do oesophagoscopy with a biopsy of the esophagus. And then you can also do distal esophageal pH measurement. Although this tells you whether or not there is gastroesophageal reflux disease and doesn't potentially rule out LPR. And unfortunately with oesophagoscopy, there's no correlation between a positive oesophagoscopy test and pH testing and LPR symptoms. Imaging, you could do barium studies, although this does lack a sensitivity. Scintigraphy can also be done, although this requires radiation. It's limited in some institutes, and there's no normative data for children specifically. Another way is dual channel pH measurement, where you test pH values in the proximal and distal esophagus. It has very good specificity, this shows good specificity, which means that there's a confidence that the great majority of pharyngeal reflux episodes are detected are real and significant. So you can confirm with these patients, although the test does lack a sensitivity, which means it cannot be used as a gold standard for LPR. Also, this test has a high cost. It has a poor compliance of patients, and it's not available in every institute. Another entity that can be used is a multi-channel intraluminal impedance testing, where they look at different areas within the esophagus and measure the pH and also the resistance within the esophagus as the food bolus goes down the esophagus. And this is done intraluminally within the esophagus and using alternating currents. And shown that 85% of proven reflux events have a pH of more than 4. And it's looked at multiple levels within the proximal and the distal esophagus, and that pH is measured. This is a very expensive test. Once again, poor compliance of patients. As you can see, it's required to go into the nose, and it needs to sort of sit there for 24 hours as the patient eats throughout the day. So most patients find this quite irritating, and unfortunately compliance is low. Also, because it's so expensive, there's limited availability of this. And in multiple studies, the correlation between symptoms and signs of LPR and positive testing, it's variable, but it has shown to be the closest to a gold standard test for LPR. But once again, it's very expensive and it's not always available. Other testing that you could potentially do is to do a restage pH study, where a probe is put through the nostril and the pH is measured within the oropharynx. It's better tolerated than the impedance testing that we spoke about in the previous slide. And essentially it detects aerialized refluxant in a liquid bolus. Its use is limited in children because it can cause gag reflex in kids. Often kids don't tolerate this very well, and it's often mainly used for adult population. And there are conflicting results with this testing. The other test that you can do is looking at salivary pepsin, where you can actually do a bedside test where pepsin assays looked within the saliva. And the initial results are variable with this test in children, but this could be something potentially that could, if more studies are done out there, could be a good test for specifically for the pediatric population. So the treatment of LPR, so it really is weighed against demonstrated symptomatic relief and benefit for children. And depending on the underlying or the associated condition of the patient, it's as an adjunctive therapy rather than just a acid suppression alone. So for children, for infants, conservative management for LPR is to normalize feeding volume and frequency. As I said in the previous slide, thickened formula seems to have a beneficial effect on these patients, and the beneficial sorry, the thickened formula has a beneficial correlation for patients with LPR. And then obviously things like OT and teaching the moms how to do non-prone positioning during sleeping, all of these things can improve LPR if it's mild, and if that is the only thing that the child has. For all the children, very similar to adults, avoid larger meals, don't lie down directly after eating, avoid caffeine, chocolate, acid, or spicy foods, and then to limit exposure to tobacco smoke. The importance really here of conservative treatment for LPR is the role of parent and patient education, and that patients understand why they need to do these specific lifestyle changes to avoid acid suppression treatment. Pharmacotherapy for LPR, it's mainly for, we can use alginates and antacids. Alginates available for children, sodium or magnesium alginate, and here patients less than 4.5 kilos, we use about a sachet a day, and greater than 4.5 kilos, you'll use 2 sachets daily in divided doses. 2 studies found a reduction of vomiting and regurgitation in patients with mild reflux symptoms, but there's no specific studies regarding non-esophageal manifestations and the use of alginates and acids. And there's really no standardized recommendation to use this in children. Prokinetic agents are unproven ineffective, and patients have progressively, and this has progressively been withdrawn in recent studies. As I said, the main main medication that has been studied is metoclopramide or Maxilon, as it's commonly known, and in 1 out of 6 controlled randomized controlled trials, there was a correlation between the use of a prokinetic like metoclopramide and improvement in esophageal pH in the proximal and in the distal esophagus. With clinical improvement found in this 1 in 4 randomized controlled trials. However, there was a higher incidence of adverse events within these trials looked at. Doperidone and erythromycin, there are no randomized controlled studies at the moment. And then you could consider baclofen and something like a GABA agonist, which inhibits transient lower esophageal sphincter relaxation. It's a central, has a central effect and can be considered when all other treatments fail. Although there are not enough studies to show that there is a significant improvement in these patients. Pharmacotherapy for LPR, looking specifically here at histine 2 receptor antagonists and protein pump inhibitors, with protein pump inhibitors being the mainstay treatment nowadays for these patients. The effects are really to produce relief of symptoms and mucosal healing of gastroesophageal reflux disease. It is the superior choice to antacids and alginates. And like I said before, PPIs are superior to histine 2 receptor antagonists. Higher doses are sometimes necessary for patients with severe or resistant reflux and can be given in twice daily doses. And since 1999, the literature has shown there's been a 750% rise in the use of PPIs for patients with both gastroesophageal reflux disease and LPR. Side effects are common in children. About 34% of kids have some form of these side effects. specifically nausea, vomiting, abdominal pain. Some have rash and urticaria with pruritus, leukoplakia, anemia, thrombocytopenia. Some kids can have elevated transaminases, which can result in gynecomastia, and in some children, less commonly, mental confusion. Long-term effects in children, as well as in adult population, is the increased infectious risk, specifically of C. diff, which has been proven in adults, where this results in bacterial overgrowth as a result of the use of PPI. And children, there has been an association with pneumonia as well, and the use of PPIs. So the recommendation at the moment for LPR, so like I said, PPIs or protein pump inhibitors are first-line medical therapy and used for 4 to 8 weeks course. This is obviously for children. And usually if you do a 4 to 8 week course, there's an infrequent resultant in severe side effects. PPIs are not recommended currently for regurgitation or crying for regurgitation, or patients or children that are crying. And these are obviously healthy children that have no other comorbidities. The recommendation is also avoid long-term treatment to prevent these more severe side effects. And so the recommendation is 4 to 8 weeks, and if there is a response, to potentially continue 6 months up to 12 months, but really not necessarily going beyond that. And it is recommended that periodical evaluation of benefits and risks need to be done with children specifically. It's important to exclude other causes for the clinical presentation in children that are not responding to 4-8 week course, and to investigate that after 8 weeks before thinking, rather than continuing on with the acid suppression. And if PPI intolerance or if there is failure, you should then try histamine 2 receptor antagonists. And then if that doesn't show any beneficial effects, then potentially surgical treatment should be considered. So the objective of anti-reflux surgery is to decrease reflux events and decreasing reflux symptoms that are resistant to medical therapy. And it has been shown that regurgitation and vomiting after surgery had an 86% reduction. Although with emetic reflux and failure to thrive and growth, there's no evidence that surgery positively affects these manifestations. And then respiratory symptoms such as aspiration, apnea, and acute life-threatening events, there's no evidence to show that this may alleviate any of these episodes. The recommendations in a few case studies and retrospective reviews, it's grade C recommendations. So really not enough to suggest that this would help respiratory symptoms. Most of these patients that do have these respiratory symptoms have some kind of underlying chronic condition. Yeah. And then patients with underlying chronic conditions such as neurological impairment, there's a 50% success rate in patients who do undergo anti-reflux surgery, although there is a high mortality and morbidity for these patients. And in patients with cystic fibrosis, symptoms were improved by 59%. with decreased pulmonary exacerbations and decreased decline in lung function. And then with regards to anti-reflux surgery and ENT conditions, there's no proof that surgery directly improves the airway. So just briefly, the different types of anti-reflux surgery. They're equally effective. We can either do a Nissen. Often these are reserved for patients who have dysphagia, and there is the TUPACE procedure which is favored in patients with esophageal dysmobility. And here, just to note that with these surgeries, it's impossible to determine if esophageal motility is primary or secondary to the gastroesophageal reflux disease. And that acid exposure correlates more to esophageal dysmotility than non-acid reflux. So, like I said before, that there is a significant mortality and morbidity with patients that undergo anti-reflux surgery. The failure and recurrence is in 15% of patients with no other disease. And then neurological impairment in neonates, in patients, in neonates and infants with neurological impairment, there is a higher failure rate in these surgeries. Like we said, for dysphagia, patients with that undergo TUPACE surgery, 10% have ongoing dysphagia versus patients who undergo Nissen, 27% only have ongoing dysphagia. Can get gas bloating as a result of these surgeries. Patients have pain, and they can have early satiety, and sometimes prokinetics and frequent feeding can assist with this. And then in rarer cases, patients can have dumping syndrome where they require continuous feeding. So in summary, LPR may coexist with pediatric airway conditions without being the cause. Which children need directed therapy still really needs to be determined, as there are a lot of co-founding factors and many patients have coexisting conditions. Good clinical assessment is needed of, and ongoing clinical assessment is needed of these patients. However, validated questionnaires still need to be found specifically for children. The tests for LPR are often quite expensive, not tolerated well by the pediatric population, and more simple, reliable and inexpensive tests still need to be developed for these patients, as these would help predict which patients will gain benefit from anti-reflux therapy. And then the other thing is to allow targeted use of protein pump inhibitors and other anti-reflux surgeries, as you need to caution because there's an increased risk of side effects in children, and then obviously the complications that come thereof. Thank you. Are there any questions?
Shavina, at this moment, we would like to invite any comments or questions on the floor. I don't know if Prof. Pierre is on the meeting, or Dr. Maguire, if they would like to comment.
I don't think they're on the meeting.
Or we can comment.
Maybe I can just.
Okay, if the patient wants to comment.
Thanks, Shavina. That's quite a comprehensive presentation. I don't see pediatrics, so but just from the otology side, obviously OME is common and LPR is common in kids. And so I think, yeah, there haven't been any studies that have proved that sort of LPR is causing the OME. It's kind of sort of often sort of, coincidentally in the same patient. And I think LPR is kind of, well, certainly in adults, it's quite commonly diagnosed. So it's quite a difficult topic. And what's quite interesting is that 10 years ago, we had the same discussion, and it's almost like listening to the exact same presentation, but 10 years later, and I think it's changed. It's a bit like gestation tube dysfunction. So yeah, I mean that's the only thing from my side. It's good. It's a difficult topic, and I think one that even if you revisit over and over again, could end up having the same discussions around it. Can I ask Asmita Patel? Asmita, do you have any comments from your side? Is this something that not sure if you're treating kids at all where you work, and whether you have an approach to the LPR in kids? Asmita?
Can she unmute?
Yeah. Definitely can.
I'd have to ask to unmute. Click on ask to unmute. Okay. What about Rael?
Also.
Oh, I've signed on as well.
Yeah. I don't know if Raphael wants to comment on the LPR and pediatric ulcers.
I think from my discussion with Prof. Peer regarding this presentation, she did mention that really it's only with children respiratory papillomatosis that there has been more studies that have been done showing that those who do have LPR and have respiratory papillomatosis, giving them acid suppression therapy has shown to improve decrease the severity of the disease. So not to the same extent as Gardasil vaccination and regular scoping and debulking, but definitely these patients do benefit from acid suppression, specifically for papillomatosis.
Thanks.
Yeah.
Okay. Thanks, Shavina. I don't see any further comments or questions from anyone. And on that note, I will end the meeting for today. Meet again on Friday. Thanks.
Thank you.